3.4, etc. So what happens here is this particular patient has 3.7 into 3.4 into a positive HLA-B27, and his likelihood ratio product was 945, and he has an 85% chance of developing a spondyloarthritis. So this is an actual computerized model. Similarly here, this patient also had a positive MRI finding which increased his likelihood ratio by a product of 9, and his likelihood ratio of having a spondyloarthropathy was 98%. So you can see that we have to first make the diagnosis, which is often tricky. Rheumatoid arthritis has a delay in diagnosis, usually anywhere between 6 months to 6 years, we saw here. And in Dubai, we found that we have an 18-month delay in diagnosis. Our patients with spondyloarthropathy had an average of an 8-year delay in diagnosis. So because we don't have a proper blood test to diagnose it, and we do have to apply judiciously these clinical criteria for diagnosis. So the assessment of ankylosing spondylitis, we find that patients have very limited lumbar mobility. This patient, all his flexion is at his hips. He's unable to touch his toes. There's a huge fingertip to floor distance. He has a kyphotic appearance, a hunch forward distance. His occiput to wall distance is greatly increased. And this is the natural progression in the old days, before we had all the wonderful biological drugs, of a patient with ankylosing spondylitis, a slow but relentless progression of axial involvement. And of course, we have other clinical features, uveitis and iridocyclitis, and several peripheral or non-vertebral manifestations, including asymmetrical arthritis, inflammatory arthritis of the MTP joints, psoriasis, psoriatic nails, dactylitis, sausage digits, heel pain or Achilles tendonitis in this slide. And just to touch briefly on reactive arthritis, usually can follow a urethritis or cervicitis, infectious diarrhea, and often associated with inflammatory eye pain or enthesitis. Now, some of the X-ray findings, you see these syndesmophytes. These are the kind of things we want to prevent. We do not want patients to develop these, and we do not want to be diagnosing and treating them at this stage. And that's why I've been emphasizing on the early diagnosis based on inflammatory back pain and other clinical features before this patient has actually developed a bamboo spine. This is the bamboo spine, and this is the stage we do not want to get the patient at, just like we do not want to get that patient in the wheelchair with rheumatoid arthritis. So we want to pick up sacroiliitis early. Sacroiliitis is something, we often get back X-rays read by the radiologist. It's like somebody's looking at them, and it may say normal, but when we look at them carefully, we have to look at our pelvic X-rays carefully. The Ankylosing Spondylitis Assessment Society recommends an PA pelvis view with hips rather than the sacroiliac joint views we were getting some time ago. So this is normal. Grade 0 is normal. Here you have normal sacroiliac joints. On this slide here, you have grade 2 sacroiliitis. I'm not sure how well this is projecting over there. I can't really see. But grade 2 sacroiliitis on the right and grade 1 on the left. And grade 1 is defined as a suspicion. If you can just turn the camera off there. Grade 1 is defined as a suspicion of sacroiliitis, that you think there is some sclerosis, but with grade 2 there's actual erosive disease here, and there is no change in the width of the sacroiliac joint. However, with grade 3 sacroiliitis, you will see that there is partial ankylosis of the sacroiliac joint in parts, or there's widening or narrowing in parts, and on the right side here, you see some sclerosis and erosive changes. And grade 4 sacroiliitis is, of course, complete ankylosis of the sacroiliac joints. So this again, just for us to remember, is grade 2 has some erosions and sclerosis, grade 3 can have narrowing or widening of the joints, and grade 4 is a severe abnormality with total ankylosis of the joints. Now, MRI has now come about as one of the most useful tools to detect early sacroiliitis, because X-rays are going to show us changes only later on in the course. So just like we have ultrasound and MRI for rheumatoid arthritis, we have MRI for ankylosing spondylitis. So here we have bone marrow edema, one of the early changes on stair sequences. And here you have bilateral sacroiliitis, again, on the STIR sequences. So you see bilateral bone marrow edema, which is one of the earliest findings we can pick up on the MRI. To pick up actual synovitis of the sacroiliac joints, we mostly need gadolinium enhancement, and here you can see synovial changes in the sacroiliac joint. And these are typical X-ray findings, some of them early: squaring of the vertebra, syndesmophytes, and then shiny corners or Romanus lesions of ankylosing spondylitis. And these are later changes, and sometimes we find it difficult to distinguish between syndesmophytes and osteophytes of degenerative arthritis, but mostly syndesmophytes are reaching up along the line of the ligaments, while osteophytes can project outwards as degenerative lesions. Again, here you have an MRI finding with early inflammation. On the gadolinium, you can see this enhancement and erosive disease here. And we're going to actually try to skip to assessment. Some of the tools which we use in ankylosing spondylitis to assess patients are chest expansion. You measure at the fourth intercostal space, and this is the position of the patient, hands resting behind the head. The modified Schober's test, you take the midpoint at the posterior superior iliac spines, measure 10 centimeters above and 5 centimeters below, and then you have to see what the maximal flexion is, and the best of 2 tries is recorded. And the occiput to wall distance is again with the chin at the normal carrying angle, and you have them touch the occiput to the wall and measure the distance here between the wall and the occiput. These are some of the physical measurements we have to make on a patient with suspected ankylosing spondylitis. Besides that, a very important tool is a patient questionnaire. The patient fills this thing called the BASDAI index. And this is very important because this helps us to judge which patient goes on a biological drug or an anti-TNF. We have to have these scores in our clinic. And often we say this is very difficult, a busy clinic, having patient-filled questionnaires is just not feasible. But one of the easy things to do is to fill a patient-filled questionnaire. They can take this home and fill it at home. And another score is BASME, which is your measurements, the lateral spine flexion, modified Schober's test, and chest expansion, etc. There are other scoring systems, the ASDA scoring systems, and also an ankylosing spondylitis, the workshop course set, which includes function, pain, spinal mobility,